This conference will now be recorded.
So tell me some examples for the communicating hydrocephalus. Any of you? Nobody? One man. So many cases we have been seeing actually. Any infection can cause hydrocephalus? Okay. Monica? Can you hear me? Hello? Pawan? Connection on that?
Yes, sir. Yes, sir.
What happened? Then everybody is silent. I don't know why. Feel free. Actually, if you just unmute and tell me. Example for a communicating hydrocephalus. An example. Any infection do you think of? Geeta Sri?
Meningitis.
Yamma? Yes, come on. Nothing
Meningitis.
No, you're not clear, Amma.
Meningitis.
Which meningitis? Usually it should be chronic process to develop hydrocephalus. So any meningitis can cause, but typically the tuberculous meningitis. TB meningitis, because of the exudates are collected on the base of the skull, they form the absorbing. Where is it absorbed? CSF usually. So there is the base of the skull is blocked with the exudates. That's why it's a absorption is delayed. Communicating hydrocephalus. Communication means between the ventricles and the subarachnoid space. So closure is any of the if the foramen of Magendie or foramen of the Luschke they are blocked, it is a obstructive hydrocephalus. Okay, we saw this already. What about this child? How do you describe him?
Marasmus.
So skin and bones. So marasmus, they will ask you grading. Actually, early stages only the body fat is lost. So if the ascending part, actually, even if the extreme, the grade 4 is actually losing the buccal fat of fat. So the last to lose is on the face. So the buccal fat of fat is also, that is the extreme case of marasmus. And mid-arm circumference, you can just imagine how much it will be less than 10 centimeters or so. Another case of marasmus. This picture is not actually good. It's supposed to be measles anyway. We will give a better picture actually. Okay, leave it. What about this one? Can you see anything abnormal in the baby's head? Hello?
Sir, wide intercanthal distance.
Emma? Wide?
Intercanthal distance.
Intercanthal distance. So what do you call it actually? Is there a name for it?
Hypertelorism.
Hypertelorism. The actual definition of hypertelorism is the distance between two inner canthi, this one, okay, is greater than the palpable fissure. So if this will be equal to this one. So intercanthal distance is actually from the inner canthus to outer canthus. This distance is, it should be equal. Whereas one inner canthus to the other inner canthus, this distance is larger than the palpable fissure. It's a hypertelorism. Actually, if actually there is a telecanthus, ideally the name is a telecanthus, but undergraduates we may not ask you actually. The true hypertelorism is actually distance between the outer canthus also is increased. So only apparently increasing called as a telecanthus. Anyway, more than that, actually the head size also is smaller here. Actually, this picture is not good. What about this child? Look at this child. Anything abnormal? Comment about the head.
Sir, head circumference is smaller, sir.
What do you call it, Amma?
Microcephaly.
Hydrocephalus.
So this child appears to be having microcephaly. Then they will ask you what is microcephaly. So the next question is, so when do you say microcephaly is
Circumference less than 3 standard deviations of normal, sir.
for the age? Okay. Then what could be the causes? Actually, so several causes. The early closure of the sutures, craniosynostosis. There are so many syndromes, congenital, touch symptom, all these things, infections, there is multi retardations, all this. And you can see the low set years is actually, if you draw a line from here across parallel to this, if the tragus is below that, it is called the low set years. Usually it should cut at 1/3 of the tragus. If the entire ear is below that, then it is called as a low set years. Okay. Now here in that one. What about this one? I'll go to the X-rays later on actually. I think they are giving, you can see the curve. What do you call this? Okay. Theology may be dictates. The appearance actually, the knock knees. Knock knees is the technical medical term is
Genuvalgum.
welcome. So because the knees appear to be closer and actually ankles are becoming distended. So most probably the bending occurred because of the rickets. Okay. And again, another case of obviously, what do you see? So this curvature is the concavity.
Playing,
And,
cupping.
fraying and cupping. Yeah, tell me, Amma. Praying and cupping, that is again typical of a, which one? This is also a case of Akhil? Yeah. Be active today, otherwise you cannot. It's also rickets, isn't it?
Sir.
This is an active rickets. I will show you the difference actually later on. So what could this be? This is one more spotter actually they may keep. So what do you see here? Closely look at it.
Zoster infections.
Zoster on a wrist, unusual. Amma. So this is a wrist, no? Actually, by dermatological terms, what do you call this type of lesion? Is it elevated or snub? With a little scaling also you see. It is a papular rash. So usually on the extremities, it is suspected as scabies. The history also is given, it is highly with itching and all this. This is a scorbutic scabies, especially intertrigo, especially joints, and this area it is a scabies. Of course, this is very simple for you. What do you see here? Come on, Jayasuriya. Clubbing. So then they will ask what are the grading of the clubbing. Okay. Initially, the fluctuation only. Then loss of what exactly is the angle between the nail bed and the nail. That is lower bound angle. Then you know the Shamrod sign and all those things also. Then parrot beaking and drumstick. These are the extreme gauges. What are the causes of the clubbing? That question may come actually. What are the cardiovascular conditions? What are the respiratory conditions? What is the gastroenterology? So can anybody tell quickly? One example. For cardiovascular conditions, what is the cause? Geeta Sri? Who will tell? Quickly open your mouth. One cardiovascular condition causing clubbing.
Cyanotic heart diseases, sir.
So congenital cyanotic heart disease, very good. Respiratory cause condition causing clubbing.
Bronchiectasis, sir.
Very good. Chronic bronchiectasis, lung abscess. That is suppurative lung diseases. Okay, you remember suppurative intestinal causes clubbing.
Crohn's disease.
Usually they say
Ulcerative colitis.
ulcerative colitis, yes, and
Crohn's.
Crohn, that is a inflammatory bowel diseases, and portal cirrhosis. Some of these conditions. Okay, we'll go to next. What type of lesions are there? Just closely see. What are these?
Macula.
This is a
Maculopapular lesion.
No, it's not maculum. You look closely. Look at this particular area where I'm pointing.
Vesicle.
So the vesicles with a little water filled this one. That is an indication of a vesicular rash. Example,
Chickenpox.
most probably chicken pox. Usually, if some may be filled with pus also, pustules, otherwise it vesicles. Another case of a bowelitis, actually you can say rickets. We'll go to that later. This is the bite spot. Bite spot, they will ask you whenever there is vitamin A deficiency, classification, WHO classification, X1, X1, X2, all those X1A, X1B. Be thorough with this, either in the nutrition part or actually in the here spotters, they will ask you. What is this girl? Comment?
Down.
Yeah, it is a Down syndrome. So
Flat nasal bridge.
very good.
I-
Now, they will ask what are the types of Down syndromes, what is the mosaicism, what is actually, what are the various other clinical features, physical features of the Down syndrome. At least 4 or 5 suddenly you must be able to say, like brachycephaly, flat head, hypertelorism, mongoloid slant, and protruding tongue. Happy demeanor, actually they are always a pleasant children. And hypotonia, small babies, they will say only hypotonia may be there. And if you look at the hands, simian crease may be there, and in the feet you see sandal gap. And systemic involvement, actually, which is the commonest cardiac involvement, actually, which is the commonest gastrointestinal abnormality, which is the commonest bony abnormality. These things they will keep on asking. So for cardiovascular, it is endocardial cushion defects. For gastrointestinal, it is duodenal atresia. For endocrinal, it is hypothyroidism. They are associated with hypothyroidism and bony defects, subluxation of the atlantoaxial joint. Actually, that is a cause of death many times, because any small jerk they may produce a subluxation, produces fracture in the cervical neck and they die. So these are some of the classification. Comment about this face. What is this?
Chipmunk faces. Thalassemia.
Yeah, it is a hemolytic faces because of the pallor and prominent malar areas, forehead prominent and pallor. This is a typical of a hemolytic anemia, most probably thalassemia. Okay, one of the examples. Right. I think we have covered actually common these things I just covered. In the Viva, I think already Madam might have dealt with this topic actually. Since Spartus doesn't take much time, actually I have taken this one. How to read anything. Some of the classes are for the sake of exams and some for the knowledge also. Though I'll just go ahead for the basic principles of how to read an X-ray. So whenever you read an X-ray, identify the part actually. This is an X-ray of, because simply saying they show X-ray of pneumonia. Sir, it is pneumonia, sir. Don't answer, jump to like that actually. So basic etiquette actually, the presence when you show an X-ray, to identify that actually, what is that X-ray, which part of the body, then it looks nice. And when you look at it, sir, it is a plain X-ray of chest, PA. If you can make out PA or not, how to make out PA, I'll tell you actually. So focus the area. If it is chest, phase of inspiration, Look at the centering and rotation, exposure quality, and then diagnostic exam. Diagnostic exam means you must start with the soft tissues, bones, clavicle and ribs, trachea, position of the trachea, hyla, how are the hilum, lung fields, cardiophrenic angles. Within the lung fields, you see vascular markings. How is the diaphragm? How is the cardiac shadow? These are the important things whenever chest X-ray you look at it actually. The rule of three, there is actually, they say three structures which are white. Any soft tissue, the bone looks white, and the heart shadow is also white. These are normal things actually. There are three things which are black. The trachea, that means all those conditions which contain A, they appear to be black. Trachea is a black. Bronchi are black. The right and left lungs, if it is well aerated lungs, they should look black. And the stomach bell, that is actually gas inside the stomach should look black. The bell, we call it the stomach bell. So when you are looking at the lung, always follow three steps. What is it? Compare the sizes of the two lungs. Are they equal or any deficiency on one side? Compare the vascularity of the two lungs, whether that is vascular markings, are they equal on left and right? Compare to hilar shadow. So you know the right and left hilum, what is their position? I'll talk to you about the actually how to say their position. Right and left are equal or not. Size, any enlargement on one side, and the shape. These are the things with a hilum. So you look at the what are the blacks and whites and the sizes of the lungs and then the hilum. The three aspects of the diaphragm and pleura, there are also again three aspects. One is the position of the left and right diaphragms. Are they normal anatomically or not? Then the costophrenic angle, that means the diaphragm where the diaphragm joins the chest wall is called the costophrenic angle. Is it present or not? Usually acutely it should be present, whether it is blunted or not. And the pleura on both sides, whether it is any specific thing about pleura. So the A, B, C, D, E, F, G, H, I of the chest X-ray reading, these are the common things. A for airway, B for bony cage, C for cardiac shadow or a cardiophrenic angle or a costophrenic angle, whatever it is, C you can use it. D for diaphragm, E for everything else. That means exposure, especially all those things actually. F for the fields, lung fields, upper, the left and right and all those things. Go for the obvious. G stands for go for obvious. Suppose there is a big round shadow in the middle. Obviously, try to find out what it is. H is for the hidden areas. We'll talk about what are the hidden areas. I is interrelated. First, combine all these things and then give your valuable opinion. This is roughly, we say A to I. So look at this anatomical landmarks. You look at this. What are all these findings? This is there is a sternum and the clavicular junctions. A is for the airway. I think I have finished actually this one. So the manubrium sternum here. The superior vena cava shadow comes on the right. You concentrate on the right side. Right main bronchus within the hilar area. Then if you see closely, there will be a horizontal line. That is a horizontal fissure. Most of the cardiac border on the right side is formed by the right atrium. Just remember, majority of the cardiac shadow is there. What forms the right border is the right atrium. Oblique fissure you may not see most often, actually very difficult. The inferior cava just at the costocardio diaphragmatic junction. And the diaphragm and the liver. This is the liver here, and this is the costophrenic angle. On your left side, so once the tracheal shadow, if you follow below, there is a bulge on the right and left side. It is an aortic arch. So unwinding of aortic arch means it will be very prominent. Otherwise, it just smoothly mixes with this. Just immediately after the bulge, what you see the pulmonary bay. You call it the pulmonary bay. If there is an enlargement of the pulmonary artery, it will be full. Otherwise, it will be concave like this. Sorry. Below, behind that is the left main bronchus. You cannot see most often, very difficult to see. And left atrium forms a small appendage, actually, if there is enlargement only you can see. Otherwise, this part is continued with the left ventricle. Left border, most of this cardiac border on the left is left ventricle. Oblique fissure on this side appears like this, and the left dome of the diaphragm and left costophrenic angle here. So left and right costophrenic angle, they are supposed to be acute. So here is the stomach bubble I am telling about. This is the general features. The first step is identification of the T1. T1 process is slanted up. This is a little slightly upward. You see that until here it is a cervical spine, thoracic spine. It protrudes a little upward. And what is just below the T1 process, the slanted T1 process, is the first rib. That is the bony identification of this. Now, I was telling actually which view it is. The differentiation between the AP or PA chest X-ray is AP clavicle at or above the apex of the lung field. In the PA, it is within the lung field. We'll show you in the actual figure. The first thing it is the position of the clavicle. The ribs, how are they placed? In AP view, they appear horizontal, whereas in PA view, they appear oblique because anteriorly they are oblique. The scapula is within the lung fields in AP view, scapula away from the lung fields in the PA view. Vertebral column distinctly appears in the AP view. It's less distinct in the. Actually, most often we follow this one. First thing, it is very prominent. If you see the left vertebral bodies very clearly, that is in AP view. That's simple. So the mnemonic is clavicle in, scapula out. That is a PA view. Clavicle in, scapula out. Look at this now. See the clavicle in, scapula out. The scapula is appearing within the lung field. You see, this is the vertical line is the lung field. And clavicle appears outside the lung almost. This is a AP view. Here, actually, bony marks, this film is not so clear actually. I will show you this one. Okay, this is better. See, AP view, you can see the clavicle shadow here vertically. Here, you hardly make out clavicle. Did you notice that? And the spinal processes are very, very prominent. They are behind the cardiac shadow in the PA view. Here, of course, it's not that clear. The clavicle is inside the lung field. You see, the lung is going above the clavicle. It is like, so clavicle in, scapula out. Here, clavicle appears above the lung and clavicle, the scapula is appears in. Look at the ribs, almost they are horizontal. Here they were oblique in PA view. Okay, these are the important things: clavicle, scapula, rib, and the spinal processes. These are the important things to make, which is prominent. So these are the points to make note of. So look at this. So which is AP, which is PA? On your right, what is it? Anybody?
AP view, sir.
On your left?
PA view.
So that is actually, obviously you can see the scapular shadow very clearly. So when such an X-ray is shown, sir, don't say it is a pneumonia directly or a pleural effusion, even if there is an effusion. So this is a plain X-ray of the chest taken in a PA or AP view. And then what other things you notice also you can see. Focusing of the expirate or inspiratory film. So what is happening is in inspiration, you are expanding the lung. In expiration, you are contracting the lung. Just as in the visual field of this photograph shows you, just like in the X-ray. Full inspiratory effect is diagnosed by, these are the parameters. Adequate inspiration shows diaphragm at 9th rib. So if you count these, actually, you see the process is starting from the clavicle 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 ribs must be able to make out, and diaphragm is below that 9, usually 8 or 9. Ensure the posterior ribs 8, anterior ribs is only 7, at least shown in a child of 3 to 7 years. So small children, 7 ribs are entered. 8 visible posterior and children is below 3 years. So for below 3 years, only 8 ribs are enough. Above 3 children, at least you must see 9 ribs, posterior ribs. So, and cardiac shadow is not merged with the diaphragmatic shadow. You see that cardiac shadow is looking separately and diaphragm looking almost separately. So that is also sign of a full inspiratory effort. Otherwise, diaphragm will go up and just merges with this one. That is inspiratory. So the full inspiratory effort means actually the diaphragm is pulled down separately. So this is an example of both on your side. You can see one is a poor and good inspiration. Good inspiration means you can see if you count 9 ribs are there, cardiac shadow appears separately. Here cardiac shadow almost merge and you can see at least 6 or 7. That's all. So the dome of the diaphragm should be over the 10th posterior rib in full inspiration. Ideal. That means full 9 ribs will be there and on the 10th this diaphragm goes up. So this is the typical of a good inspiratory film or expiration. And also you can see the darkness of the fields also. So because full of air, the lungs appear much more dark in inspiratory because the small amount of air in the lungs, this appears less blackish. So these are the differentiation of how to make out inspiratory, expiratory film. And now the question is centering. After you have seen inspiration centering, so the tracheal shadow and the clavicular inner ends usually help this alignment. Thoracic spine to the center of the medial ends of the clavicle or centrum of the sternum. So thoracic spine position compared to these inner ends of the clavicles, that helps you how is the centering is done or not. See, looking that this is the inner end of the clavicle. This is the center of the spine. So if on both sides equal distance, that is a well centered one. See, look at this film. See, if you draw a line, this center line has actually gone to the left. So such film is not as properly centered. So your interpretation may change. Uneven distance between the median ends of the clavicle and the central line. That is a typical of a not properly centered. Children, because it always happens. Next is a rotation. So not because of the film centering, the child has rotated because they keep on moving, no? So B is rotated to the left actually. The child has turned it towards a little left. The heart appreciably in the left homothorax. It appears to be in the, and the left side of the chest is relatively elongated. So it appears to be long as compared to the right side. So now the opacity of the right lower chest field. So right lower chest field where there is an arrow, the reverse is true in the E. So if the child is turning, rotated left this side, the most of the heart has gone inside and this appears to be longer than the left. So this child has got rotated to the left, whereas this is a proper, not so rotated actually. Compare the both limbs. This on your right is a normal film, on your left is a child has rotated to the left. Long lung field and lower chest fields. There is an opacity appear. Actually, it's not an opacity because of the rotation. Now comes the exposure. You can see the light, actually, the lantern. The hardly you can see on your left. Gradually, if you increase the exposure, here you can see very clearly, but it becomes very, very faded in the right extreme. That happens actually. Same thing. If the film is underexposed, it appears like this. Normally exposed, it appears to the center. If it's overexposed, it appears so dark. So these are the three extremities actually. So from this you can make out how a film is exposed, how exposed, normal, underexposed. The small lung lesions may be missed by overexposure or underexposed. So they are more black because this hardly you can see anything, details of the lung vascular markings, anything actually. And can be misinterpreted as an emphysema because emphysema means more air inside. You think it is more air actually. It's not because the air, but it's an exposure. So interstitial markings may appear prominent and may be mistaken for interstitial disease. So all these vascular markings, they appear very prominently in a case of underexposed films. You can see underexposed film, so streaks you can see more. So you think it is a most probably interstitial pneumonia or something actually infiltration. So here you don't see that marking so much, you see. That is the difference. That is interpretation should be better. Look at the clarity with which you can see the intervertebral space over the cardiac density. You can see clearly cardiac density is there. Over that, you can see the spaces also. It should not be like that because you should not be able to see the intervertebral spaces so clearly behind the heart. Actually, somewhere else you can see. So this is an overexposed film. Another example is the penetrance is nothing but actually exposure only. So this is an underexposed one with very streaky markings. This is an overexposed film with hardly you can see any details at all. Now come to the diagnostic aspect. These are all the basic underlying thing. Now you come to the diagnostic. You can see this is a normal chest films. You can see very, very well exposed, well centered when there is no rotations, good exposure and all these things. This is AP because the horizontal spine, this thing, and you can see the spines very clearly. Now look at the subcutaneous tissues. Whenever the chest film you see, you don't see anything, you may miss, you always keep looking at the lung fields and other things actually. So look at this sub, there is air inside the soft tissue area, which is there, not supposed to be there. Or you can see that in the when X-ray there is a small spots here. These are the calcified lymph nodes. So you have to be concentrated before you go to the bony cages and other things. In this soft tissue also, they give some indications. Look at the clavicle. So in the palm, there is a small crack here. So all the time you are looking at the lung fields, you are missing that. You can look at this is a healing clavicular fracture. So a lot of swelling. Usually why there is swelling here and actually thin here. It is a healing clavicular fracture. This is a fresh fracture. So like that, certain things you may miss it. So deformities and rib fractures. You can see so many rib fractures. In this film, actually enlarged for you. But in the small film also, you must be able to see so many things, disturbances here. They are all healing ribs. That is it. So such things you should not miss. Now, one more important thing is the tracheal position of the trachea. The trachea appears dark heighted. Actually, it is in the midpoint of the two clavicular line. Here, the trach line has gone to one side. So why is it still? There is a big pneumothorax here actually. This is pushing it. So lung has been enlarged on this side and you can't make out the vascular markings so clearly as on your right side. So this is a typical of a pneumothorax. Entire pleural space is the air that has pushed the trachea to the right. Now I was talking about the hilum. So the hilum is where the vessels and bronchi emerge and enter these lungs. So usually left hilum is a little higher than the right hilum. Left margin of the left hilum is a level at the upper margin of the right hilum. So this is the hilum here and center is almost coinciding with the center, the upper border of the right hilum. So this is a normal phenomenon. If this right left alignment is changed also, there is abnormal actually. So this is a symmetric density of the markings are almost equal on both sides. This is how it should be, normal X-ray should be there. Now look at this one. This right hilum is displayed almost same size, either because of this is shifted up or this is pulled down. Both are possibilities. Superior displacement or horizontalization of the right hilum while curved air. This is the curved air, this is shifted due to atelectasis of the right upper lobe. You can see that collapsed lung actually is straight lining. So what happened? This collapsed lung has pulled the hilum up. So even if you miss this one, actually look at the first, you are first seeing the hilum. So why the hilum are the same side? Pathology on this side or that side? Look at this collapsed area. The black arrows are showing that. So the hilum is found in the red arrows. And this on your left, on your right, left lobe of the lobe atelectasis, you can see here. You can see one small gradual, if you see carefully, one line inside that. So this straight line inside the cardiac shadow is nothing but a collapsed lower lobe actually. So what has this done? It has pulled the hilum. The blue arrows point at the edge of the triangular area. The left hilum displays pull down. So right hilum appears to be a little higher than the left hilum. So this is either we cannot something push the above or pull down. You have to see where is the pathology like that. So these are how hilum's position about it. Now coming to the lung fields, when you are examining lung fields, we decide the apical lesions, upper zones between the apex and this area, this one, mid zones and lower zones. We divide it like this actually. So apical zone is above the level of the clavicle, and upper zone is below the clavicle, above the cardiac silhouette. Cardiac silhouette starting from here, no, just above that. All this area is upper zone. And the mid zone is at the level of the hyola. So on either side, hyola is there, and lower margin, from lower margin second rib to the lower margin, the fourth rib. Lower zone is in the fourth rib to whatever the under the diaphragm is the lower zone. So that is the anatomical markings. If somebody asks you, always give a bony markings. Okay. Now about the costophrenic angle, I was talking about this. This should be acute. Both sides, you see whether it's sharp or looking at the X-ray, you must be able to first make out of this one. So blunting of the costophrenic angle is an indication of a fluid inside the pleura. Always remember that. If any amount of pneumonia won't blunt it actually. If this is blunted, it is definitely there is an effusion. Even if in pneumonic patch you see also there is a pneumonic effusion also is there. So this is what is called by blunting. See on your left side there is clearly the acute angle is there. Here you don't see the acute angle, it is a blunted. So this is a pleural effusion. Fibrosis is rare in children. Fibrosis also can produce that, but still in children generally don't diagnose fibrosis. It's very, very, very unusual in the children. The vascular markings are more prominent at the base of the lungs compared to upper lungs. See, there is a usual normally. The vascular markings are more. So this paucity of the vascular markings in the outer third of the lung fields. So this is how upper zone, mid zone you divide, and vertically these are the outer zones, and this is the mid zones, and these are the inner zones. Actually, the vessels on this outer side of this black mark are actually scanty. That is normal phenomenon. So this is how you see more in the central vascular markings and more in the lower parts. Right diaphragm is higher than the left diaphragm because of the liver. Congenital position of the heart determines the diaphragm is lower. So here diaphragm is flat. It's not higher, almost same size. So something is pulling or something is pushing from there. This is abnormal. The flat diaphragm is an abnormal thing actually. Now, if you see such an X-ray, there's so much of hair shadows and various things. This is the bowels are moved into the lungs. This is a typical of a diaphragmatic hernia. See, there is a diaphragmatic hernia. What is the foramen of Bokada like? Foramen of Margagna, they will ask you actually. So you can also hear the bowel sounds, Borga, Barbar, there. Now, air bronchogram sign. When internal tubular outline of the bronchus is visible in the thoracic capacity, that is called the. See, you can see the inside the bronchus. Again, there is air is there. You can see the walls. So this is there is an opacity, but inside you can see the air bronchogram. This is a typical of a pneumonic consolidation. If it is a fluid, you won't see the division. So this patch is not a uniform patch. You can see air bronchogram inside. That is called the air bronchogram sign positive in case of a consolidation. Right middle lobe consolidation. Why is middle lobe? I'm telling again because if you can make out the shadow, that is silhouette sign. Next slide, I will show you silhouette sign. What it is? Though it is appearing in the lower zone, it is not a lower lobe consolidation because it is obscuring the right cardiac border. I'll go to that. The clues of consolidation is if the right heart border is ill-defined, it is middle lobe. Left heart border is ill-defined, it is lingular consolidation, lower lobe and especially the lingular consolidation. Right hemidiaphragm is not clearly shown, it is a right lower lobe. Left hemidiaphragm is not clearly shown, it is left lower lobe. That is a simple rules to remember. Always just take a screenshot and remember this thing actually. Okay. Now, this is what is silhouette sign. Actually, absence of silhouette sign is nothing but the absence of silhouette. Silhouette, all of you know, is shadow over shadow. The left lower lobe, because of the left dome of the diaphragm is blurred. You can see, can you see the diaphragm here? No. So that means it is a left lobe of pathology. This is a diagrammatic depression. Can you see the left border of the heart here? No. So that is a lingular lobe consolidation. Can you see the right border clearly here? No. That is a right middle lobe consolidation. Can you see the diaphragm clearly here? No. So that is a right lower lobe consolidation. So the A, B, C, D are typical of all the how X-rays you have to model. This is only diagrammatic representation of the silhouette sign. So this is a simple rule. If you remember, whichever border is absent, they're not clearly made out, that will give you the location of the pathology. So this is Silhouette, and you can see, can you make out the right border here? No. The obscuration of the right border due to density of another tissue. So intrathoracic lesion touching the border of the heart or aorta or diaphragm will obliterate the part of the border on the radiograph. Intrathoracic lesion which is not anatomically contiguous to the border, it will not obliterate. Okay. Chest X-ray of the blurred missing interface is referred to as a Silhouette sign. Nothing but a appearance of a blurred or missing interface is called as a Silhouette sign. See, right border, can you make out? No. That is a middle of consolidation. Air bronchograms, and again I was talking just now, it is a, and also Silhouette sign. Here both are positive. Air bronchograms are positive, Silhouette sign is positive, right middle lobe consolidation. Here there is some amount of patchy consolidation here also, because left border also not that clear. So there may be bilateral pneumonia. So this is a patch here, but you can see the right border clearly, and there is a middle zone. This is an upper lobe consolidation, right? Upper lobe consolidation. See, lung abscess. See, whenever you see any shadow, look, if there is a clear line like this, look at this line, very, very clearly shown. That is an air fluid level. So even if there is any pathology, that is typical of a cavity is there with fluid. There, if the wall is so thick, that is an abscess. If it is a wall is thin, it may be simple cavity. Actually, maybe congenital cavity or a emphysema related cavity or a bleb inside, whatever it is. So depending upon the thickness of the cavity, decide is an abscess or any other cyst. So usually abscess are with a thick abscess, and fluid level is there. Air fluid level inside a round figure. That is a typical of abscess. Never miss such a straight lines inside. Here, this is a, you see, shadow, cardiac shadow. Inside there is another line is there. And this is the diaphragm shadow. Diaphragm is pulled up, and there is another shadow. This is a collapsed left line. So that is a left lower lobe collapse, because the shadow, triangle shadows are always collapses. Okay. Here you can see there is a straight line obliquely, and the hila are almost equal in size. That is a right upper lobe collapse. This is a horizontal fissure actually. You can see it's pulled upwards. That is a right upper lobe collapse. Whenever straight lines are there, it is a collapse. What about this? Opacity with, is there air bronchogram inside? Yes. And can you see the left diaphragm? No. So that is a left, which lobe?
Lower lobe.
That is the left lower lobe consolidation. Dark, the lung fields you see here, the diaphragms are okay, costophrenics are okay, the position slight bending is there, trachea is deviated slightly to the mid or left or right. So trachea is deviated to the right. So is it a pull or push? Let us see what it is. This side nothing appears to be any collapse or nothing is there, but on the left side, compare the shadows. Here you can see
Pneumothorax.
this is dark, and actually very hardly you can see any bronchogram in the air bronchogram. This is a air inside
Pneumothorax.
the pneumothorax pushing the trachea to the opposite side. So that is a pneumothorax. That's how you make out a field differences, actually depth of darkness. So the tension pneumothorax is nothing but actually it's much more forcible, and actually, and it may shift the mediastinum also. So then is it nothing but action. Now look at this one. Apart from the field's prominent markings, where are the costophrenic angle on the left side? So when the costophrenic angle is disappeared, what is the it is
Pleural effusion.
Effusion. Always it is a blunting is always liquid, pleural effusion on the left side. So whether it is trachea is not pushed or mediastinum is not pushed, that is a different thing. In spite of that, maybe it's not that much actually, but radiologically it is showing this thing. Here you see the clear line actually, but not inside any cavity. It is general, entire lung is actually, there is a clear line. That means below the costophrenic angle missing. So there is a fluid here, definitely, pleural effusion, but line shows there is air above that. You can compare the lung fields here. Actually, you can see the lung very purely dark, and actually the markings are there. So his air is also there, fluid also there. This is a hydropneumothorax. That's how you make out hydropneumothorax. Looking at the lung, you have to realize that. So this is a blunting flat line is indication of the air fluid levels. That this is a ground glass appearance. You can hardly make out any lung. And also small baby. Obviously, the X-ray enlarged, but actually they appear to be very small baby. So that is a case typical of a HMD, hyaline membrane disease, or respiratory distress syndrome in a newborn X-rays. So when your actual X-rays is given, it will be very small X-ray that itself shows is the newborn. If you are showing in a computer, you may not make sizes, you cannot make out here, but it is a ground glass appearance, is a typical of a RDS. Again, look at this. What are these patches there? So what could it be? Can you make out the right border? Yes, right border is clear. So there is a highlight prominent. There is a patch definitely is there. So what it could be? So right side pneumonia, most probably in the right upper or lower lip. We cannot make out actually that one. What about this one? Look at this. Typical of a reticular pattern, entire lung. This is a true diagnostic actually. It is a spotter. Can anybody tell what is this?
Miliary TB, sir.
Excellent. That's very good. That is a miliary tuberculosis. The moment they put this X-ray, you must be able to say, sir, this is a diffuse, small, mottled appearance of a lung, typical of a miliary tuberculosis. This is an expiratory film. Right hemidiaphragm was cephaloid and expect with as with, but the left diaphragm is relatively immobile. So it's expiration, what will happen? The diaphragm has to move up, no? So only small 6 or 7 ribs are shown. There definitely is an expiratory. So the diaphragm, but why this has not moved actually? So there is not moving at all. This confirms like there is an emphysema. This is actually darkness also increased, but the 8 markings are there. This is an emphysematous chest. Most probably a foreign body in the left main bronchus. So maybe that is actually causing a air trapping here. So you need not tell the diagnosis, actually etiological diagnosis. So here both lung fields, it's why it's not pneumothorax is you can see the air markings inside. If it is pneumothorax, it is really much more uniform dark here. And also that's it. The trachea is pushed actually little. Mediastinum not much of shift. Emphysema on the left side. Now this you can see here. So diaphragm is clearly seen. There is air below the diaphragm level. This left dome and right dome clearly shown. Lung field are also equal almost, but this is very abnormal. Below the diaphragm, there should not be air at all. That is pneumo. What is it? The air below the diaphragm. What do you call it?
Pneumoperitoneum.
Very good. That is pneumoperitoneum. So look for that very clearly diaphragm shadow. There is air inside. There is pneumoperitoneum. So we'll come to the cardiac and actually cardiac not much. This is how to make out a cardiothoracic ratio. So heart is enlarged. How will you say? You just draw a line in the center. Maximum diameter on the most prominent area, because left side it is a little up, the right side is a little higher. So you take this half here. This measurement here you take on the left side where it is the most extreme one. So you measure this and add this much. That is called as cardiothoracic. This is the cardiac border, and thoracic is inner side of the lowermost side of the ribs. So this is a chest, this and this is a cardiac diameter. So cardiac CT ratio. If the cardiac thoracic ratio above the 50%, if this makes more than 50 of this one, that is a cardiomegaly in a child. The cardiac thoracic ratio must not be more than 50%. This is a situs inversus. Actually, the diaphragm on one side. We generally don't keep for the undergraduates, don't bother, because stomach bubble is on the other side. This is called the mitralization, where you expect pulmonary artery here. Actually, when the pulmonary artery is prominent, it will fill the gap between the aortic arch and the left atrium. So if this is actually beige, always it should expect a concavity. If it became convex, that is an indication of the enlargement of the pulmonary artery, as happens in the mitral stenosis. So this is the X-ray. So imagine if there is a where is this water bag. This is called as a pericardial effusion. So it's resembling a water can here like this. This I'll skip. See the boot-shaped heart, all of you know, the apex is elevated from the diaphragm. This is a typical, if you put a boot, it will fit in there. So boot-shaped heart is a coherent sabu, it's called as, it's in a tetralogy of Fallot.
Tetralogy.
And also lungs are always, you see, hypovolemic actually. They are not much of vascular markings. That is a typical of a pulmonary stenosis because of that. So decreased pulmonary flow and elevated of the apex, that is an indication of the right ventricular hypertrophy because right ventricle is behind and is pushing the left ventricular tip above. So that is the cause for the elevation above the diaphragm level. The apex you always expect on the level of the diaphragm. So that is it. This is egg on end appearance. You just imagine there is egg is kept on a wire line on a string. So this is the egg on end appearance indication of a, what is it?
Transposition of great arteries.
Very transposition of the great artery because one over the pedicle becomes narrow because aorta and pulmonary on the same one over the other on the anterior posterior way. So the pedicle becomes narrow, cardiomegaly is there below. So there is an egg on end appearance. This is a typical of a tetralogy, the transposition of the great arteries. This is a figure of 8. A snowman appearance are also figure of 8 because the pulmonary vessels are reaching above the level of a this thing, obstructed transposition of the total anomalous pulmonary venous drainage. So, snowman appearance typical of a. This is a notching of the ribs. So actually, it happens in the coarctation. If you see closely, only you can see that ribs are not clear. So these are because of the collaterals. Very difficult to make out a little. Just observe if nothing else is there, you just observe the rib margins here. Coarctation of aorta. Curly's B lines, you see the small streaks, very, very difficult to make it. They say in the adults, not in the pediatrics at least. In case of a left ventricular failure, these are the lines, horizontal lines in the lowermost part of the costophrenic angle. It's called as a Curly's B lines, they call it as, because of the pulmonary edema, heart failure cases. So, and after all the theory, now I come to the practical aspect. I'm just, time is ending anytime within 3 minutes. Okay. What films we keep in the chest x-rays for undergraduates is, so there is a mediastinal widening. So you can, there is a very bad film. We'll try to give a good film. Actually, there is an indication of the lymphadenopathy, either malignancy or tuberculosis. This is rickets. All of you know, they'll make out a cupping and fraying. You see, cupping and fraying, these two words has to be under mineralization, diminished ossification of the carpal bones, swelling of the lower ends because this is the outside, the soft tissue swelling. These are the typical, and actually bowing of the legs and genovalvular deformities. And this is also another case of a healing rickets because the dark lines appear here. So the difference between this and this is, here there is no dark line at all. This is an active rickets. Healing rickets, almost here also you can see the fraying, but there is a prominent line of provisional calcification. That means actually you have started giving vitamin D and calcium, mineralization is starting there. So this is a typical of a healing rickets. When such a film is kept, you must say it is a healing rickets. Scurvy, all of you know the typical lines, subperiosteal hemorrhages are there. This carbotic, the Trummerfield zone is called a hypodense area. That is a Trummerfield zone, and followed by the dense zone of provisional calcification. This is a white line of Frankel. It is the, and a ring of epiphyses. The epiphyses are always with a peripheral ring. There is a Wimberger's sign, and Pelkin's spur is a protrusion of this dense calcification over that metaphysis. It is called as a Pelkin's spur. So these are some of the prominent features you see, and this is not more of a diagrammatic, actually not true X-ray actually. So, beaten silver appearance, indication of the rise and intervention. Now, once the sutures are closed, you get this one. Otherwise, you just widening of the sutures. So this is how we look at beaten silver appearance appears. And this all of you know, hair on end appearance, that is a case of typical of a thalassemia. So that is means because the extra bone marrow, that is yeah.
Extramedullary hematopoiesis.
The erythropoiesis is caused this one, this cause of this one. And here you can make out the cortex and the medulla. That is a typical of a solid bones. This is an indication of osteopetrosis. These people present with anemia and other problems. So hardly you can make out any difference between the cortex and medulla. that is an osteopetrosis. Plain X-ray abdomen, multiple fluid levels, that is an indication of small bowel obstruction. So many fluid levels are said. If you say, you have to say this is a plain X-ray abdomen, the abdomen are in the erect posture. First, look at the film given, identify the body part. Is it a chest or abdomen or anything? How is it taken, abdomen or erect or not? And chest, if it is, already points are already told you. And then you give start narration. What is this? This is an example. For example, I'll show you this X-ray. Sir, this is a plain X-ray of the chest taken in full inspiration. This is so many ribs are there. And exposure is good, centering properly centered. The costophrenic angle is obliterated on the left side, sir. So there is no air bronchogram inside this opacity. Probable diagnosis, left-sided pleural effusion. If you share these diagrams, you are just through 2.5 marks out of 2.5 marks. Just see. I want all of you to get this 2.5. Half mark is also, don't sacrifice it. So this should be your narration. Sir, this is plain X-ray. Shortly says that pleural effusion. Don't just jump to that. Again, why do you think it is pleural effusion? All these things are nuisance. So you are shown this X-ray comment. Sir, this is plain X-ray. Taken in a AP view or PA view, whatever it is, because no scapula are there. It is a PA view. Exposure is good, centering is good, opacity, and you see an opacity on the right lower zone, sir. Because the costophrenic angle is not there, it is most probably fluid, and there is no brain bronchogram inside, it is fluid. Left side, left side, that's finish. What extent questions? Why the differential causes of the differential pleural effusion? Why it is called TB or empyema, CHF? What clinical features you say? Diminished blood sounds may be there, sir. Stony dullness will be there. Diminished AR and VF there on that. So if you are answering, you want more marks. Actually, these questions will come. How do you differentiate between exudated and transudated? Because cell count, protein, gram stain, and culture sensitivity. What are the treatment modalities? So if it is tuberculosis, you give steroids. Needle aspiration for diagnostic, and sometimes it is a empyema. You have to see if it is pus, really thoracic tube has to be drained, otherwise it won't come out. All these are the treatment modalities like this. Okay, guys, I think time is over. With this, thank you. Any other questions? When you come back, you can ask me. Okay, I'll stop recording. Thank you.
Sir, please share the PPT, sir.